Hello everyone. This is a talk on transport physiology which aims to cover most of this section of the DIPFARM curriculum, and I've based it around the pre-hospital and retrieval textbooks that we've got here, as well as some online resources and articles. And so it contains some basic science, physics principles, equations that keep coming up again and again. So I think are probably fair game in terms of our written exam. But I've also tried to put it into a bit of clinical context for us so that it is relevant for our day-to-day practice and our patient care, and also be hopefully of use and interest to those of you who aren't in the diploma as well. And so what I've tried to do is bring together what appear to be the key physiological challenges that ourselves and our patients will experience during transfer, and these are the things that come up in the DIPFARM curriculum as well. And it seems to be based around these 8 stresses of flight, which have been described by the US Air Force, and they've conducted probably the most research on physiological challenges during flight, which they're clearly interested in from their point of view in terms of the challenges that their pilots and air crewmen will experience. Now, the stresses that we will be exposed to will be far less than what US Air Force pilots will be exposed to. However, our patients who have some pathological process are able to tolerate these stresses generally a lot less. And so that's why we're interested in how it can affect them and what we need to do to manage it. And so these 8 stresses that the US Air Force have described and come up in the textbooks and in the DIPFARM curriculum, the first 4 there you can see are related to altitude, so be relevant for our fixed wing and our helicopter jobs. The bottom 4 are equally applicable to our road transfers as well. And then the final thing to mention, which again comes up in the DIPFARM curriculum, but also hopefully will be of some practical use to some of us, is about motion sickness, and that's something that clearly we can experience as well as our patients, and just some of the evidence behind the management for that and what we can do if it happens to us or a patient during a transfer. So we've been interested for quite a long time in the effects on the human body of increasing altitude, and back in the 1870s, scientists were conducting high altitude experiments in part to see who could fly the highest, but also to see what effects this had on the human body. And these 3 French scientists in 1875, they knew that they would need supplementary oxygen as they ascended, so they filled these stripy balloons with oxygen and had breathing tubes attached. And they ascended to what was ultimately a height of about 28,000 feet. Now, unfortunately, as they ascended, they became, as they knew they would, increasingly hypoxic, but with that disorientated, confused. They also became hypothermic, and so they didn't use these oxygen balloons, and 2 of the scientists died. And so this made us realize as a human species that we are not designed to be at these altitudes, and the physiological stresses that this provides can be fatal. And so a couple of hundred years later, this quote, "Aeromedical transport of patients presents no problem so long as one remembers that man has adapted for life at sea level," just highlights that. And so what we need to establish is what the physiological changes are that happen as we increase in altitude, and how we can mitigate these effects. So as we ascend with altitude, the barometric pressure drops, and we have a barometric pressure because the atmosphere, the air around us, the air molecules have a mass, and because they have a mass, they therefore have a weight when gravity exerts its effect on it. So and the barometric pressure is essentially the effect of the weight of the atmosphere on it. So if we imagine a glass cylinder extending from the Earth's surface all the way up through to the outer edge of the atmosphere, the weight of the atmosphere in that glass cylinder gives us our barometric pressure. And if we were to ascend halfway up that glass column, there would be less atmosphere above us, and so the weight of that atmosphere would be less and the barometric pressure would be less. And so at the Earth's surface, the pressure is equivalent to 1 atmosphere, we call it, but that's the same as 760 millimeters of mercury, or 101 kilopascals, and it drops all the way up to an elevation of 50,000 meters, 50 kilometers, where the pressure becomes essentially 0. And the drop in barometric pressure has these 4 effects that we're concerned about in terms of our physiology. So there's a reduction in the partial pressure of oxygen, a reduction in the humidity, a reduction in the temperature, and an increase in gas volume in gas-filled cavities. And these are the four stresses that are described as being affected by altitude. And so we'll take each of these four physiological changes in turn, the first one being hypoxia. And this was a study in 2007 which just quantifies that effect of altitude on our oxygen levels. And in this study, some volunteers climbed up Mount Everest and they performed femoral arterial blood gas sample analysis on each other at various different elevations. And so this chart just shows some of the elevations that they performed their blood gas sample analysis at, and with it the barometric pressures PB and also the inspired partial pressure of oxygen, the PiO2. And we can see here in this table the four subjects at what was the highest elevation they took the samples at, which was 8.4 kilometers or 27,500 feet. And what you can see here is the PaO2 mean of 24 and the oxygen saturation mean of 54 just demonstrates, it just quantifies that degree of hypoxia that we get when exposed to these high altitudes. But also it shows us that fit individuals who have had time to acclimatise can tolerate remarkable physiology and not just survive, but actually function at a high level. They were still climbing up and down Everest, and they were performing femoral arterial blood gas samples on each other, so they obviously had good cognitive and motor function with that. So what we then need to figure out is why we become hypoxic with increasing altitude. And what the atmosphere is composed of doesn't really change up to about 70,000 feet, so there's 21% oxygen throughout that range. But what does change is the partial pressure of oxygen, which drops as we increase with altitude. And the reason for that can be explained by Dalton's law. Now, Dalton's law states that the total pressure exerted by a mixture of gases is equal to the sum of the partial pressures of the individual gases. So what we can see here is that air cylinder at the end has a pressure. Now, as we increase with altitude, that pressure will drop, and therefore one or more or all of the constituent gases' pressures must drop. And the reason we're interested in the partial pressure of oxygen is because of Fick's law, which states that the rate of diffusion of a substance across a membrane is proportional to the pressure difference, so that delta P we can see there in the equation. And so what that means is that if we increase the partial pressure of oxygen in our alveoli, we will increase the driving pressure of oxygen across that membrane and therefore increase our arterial partial pressure of oxygen, which is what we're really interested in. And so the final thing on this that we have to be aware of is that the gas in our lungs is slightly different to the gas outside of us, and that's because of a couple of things that we do to that gas. And this is described by the alveolar gas equation, which estimates our alveolar partial pressure of oxygen, the P big A, O2 there. And the two things that we do to the gas is we add CO2 as we've generated CO2, and we humidify the gas. So what this means is that we have to account for that in our partial pressure of oxygen. The saturated vapor pressure of water is 47 millimeters of mercury at body temperature at 37 degrees, and that's our body assuming our body temperature remains constant as we ascend in altitude. That means that we will have to take off that 47 millimeters of mercury away from our allowance, if you like, of our partial pressure of oxygen. So if we look at our Dalton's diagram there, that H2O cylinder will remain at 47 millimeters of mercury. So if the air cylinder drops, there'll be less allowance there for the partial pressure of oxygen, which is what we're concerned about. And the same thing applies to the PaCO2 there that we're generating. That R is something called the respiratory quotient, which is a ratio of our oxygen consumption and CO2 production, and we don't really need to worry too much about it, but essentially it's normally 0.8. But what this also shows, this equation, is that the two ways that we can increase our alveolar partial pressure of oxygen is to increase our FiO2, so increase our inspired concentration of oxygen, or to provide more driving pressure, increase that driving pressure of oxygen across our membrane. And that's intuitive and makes sense to us because when we have hypoxic patients, the way we treat that is by giving them more oxygen or by positive pressure ventilation to increase their mean alveolar pressure. So as we ascend with altitude, the partial pressure of oxygen in the atmosphere drops, therefore the partial pressure of oxygen in our alveolar drops, and ultimately our arterial partial pressure of oxygen drops. But what we then need to establish is what this means to our patients, and to do that we need to know what sort of altitudes we're exposing our patients to. So this is a topographic map of New South Wales, which just shows some of the elevations there, and Katoomba is the highest place that we will frequently go to, just over 3,300 feet. The highest helipad in New South Wales is at Parisha helipad in the Snowy Mountains, and that's at an altitude of 5,700 feet. That's a little bit further south of Canberra, and it's somewhere we don't often go because Canberra often go there, but that's technically the highest one in New South Wales. But obviously it's not just the altitude at our destination, we have to get there, so we have to fly there first, so we'll be flying at a higher altitude than that. And so this diagram just aims to put that into context there so we can see sea level and Katoomba. And when we fly in the helicopter, the altitude that we're flying at will vary according to the terrain and the weather, but we might typically be flying at 3, 4, 5,000 feet. Apparently when we fly out to Orange we might be going about 6,000-7,000 feet. But the rules for the helicopter are that, or the rules in Australia from CASA are that you cannot fly higher than 10,000 feet in a non-pressurised cabin without there being supplemental oxygen for the crew. And obviously we have oxygen on board for the patient, but we don't have oxygen for the crew. So we're limited to 10,000 feet as the absolute highest we're allowed to fly. Now, from speaking to the pilots, we very rarely would fly at 10,000 feet, if ever, but that's in theory the highest we could go. Now for the fixed wings, the King Airs can fly up to a height of 35,000 feet, but they'll typically fly around 22,000 feet or so because that's the most efficient cruising height for them. And when the pilots get a job, they put it into their computer as part of their flight plan, and depending on the weather and that sort of thing, that'll tell them what the most efficient altitude to fly at will be. But the rules for the King Air are that when there's a patient on board, the cabin must be pressurised to 4,000 feet. When there's no patient on board, so when we're going out to a job, then the cabin has to be pressurised to 7,000 feet. Now to pressurise the cabin, to 4,000 feet, the aircraft can be no higher than 21,000 feet in absolute altitude, and that's because of the pressure differential that can't be too great. So the aircraft frame is rated to a certain pressure differential, so if the pressure is too high inside compared to outside, then that can put some stress on the structure of the aircraft, and so that pressure differential isn't allowed to go above a certain amount. So that's why we can't fly higher than 21,000 feet with a patient on board. But essentially, bar an emergency or a sudden cabin decompression, then we're not exposing our patients to anything above 4,000 feet of sort of effective altitude. So what we can get from that is that overall we won't be exposing ourselves or our patients to anything higher than an altitude of 10,000 feet. So that gives us a bit of a range to work with in terms of seeing what clinical significance this could have. So going back to the effects on oxygenation, then this chart just shows the barometric pressure at these different elevations, and therefore the atmospheric pressure of oxygen, and gives values that have been described in healthy volunteers for what you might expect to see at these different altitudes. So for example, a healthy patient who has oxygen saturations of 98% at sea level, you might expect at just over 3,000 feet that to have dropped by a couple of points, and up to 10,000 feet that might be in the high 80s. So that gives us an idea about some of the change we might expect to see, although, as I say, this is in healthy volunteers, and so our patients with some cardiorespiratory pathology might have a greater change in their oxygen saturations with that. Now there are these 4 stages of hypoxia with increasing altitude, and I mention these because they come up in all of the retrieval textbooks, but there's going to be of no relevance to us unless we have a sudden decompression of the cabin in a fixed wing job, because otherwise we're always below that 10,000 feet. But what this gives is an idea of the symptoms that we might experience in someone who has not had time to acclimatise and is suddenly exposed to these elevations. So the first stage is the indifferent stage of less than 10,000 feet altitude, which is what we're always going to be in. And in that stage, a fit, healthy person would expect to have saturations in the 90s, but they may have a deterioration in their performance of novel tasks and a reduction in their night vision. The next stage up of between 10 and 15,000 feet is called the compensatory stage, and in that stage, our oxygen saturations would expect to be 80 to 90%. We increase our tidal volume predominantly, but also our respiratory rate. Our heart rate goes up, and we start to get some hypoxic pulmonary vasoconstriction in this zone. And we would feel lethargic, we'll feel sick, be dizzy, have a headache, maybe impaired coordination. And then above this, in the disturbance stage at 15 to 20,000 feet, our oxygen saturations would typically be 70 to 80%. And we may have a reduced level of consciousness in this, certainly poor vision, again, headache. And above that, at the critical stage above 20,000 feet, our oxygen saturations would typically be below 70%. And we'd have a reduced level of consciousness, seizures, and death. And there's also this time of useful consciousness concept, which I mention again because it comes up in the textbooks, although it's not going to be relevant to us bar a sudden cabin decompression. But there's this idea that when suddenly exposed to altitudes, when we've not had time to acclimatise, we have this short period of time before we lose consciousness. At 18,000 feet, we've got about 30 minutes. But if we ascend up to 35,000 feet, which often commercial airlines might be flying at, and we have a sudden cabin decompression, we have about 30 seconds before we would lose consciousness because of the physiological changes. And so that's why when we have safety briefs on aircraft, they say to apply your own oxygen before anyone else's, because you've got a short period of time before you lose consciousness to perform that task. And I think the final thing from a hypoxia point of view to mention from the theoretical side of things is we can calculate the required inspired oxygen concentration at various altitudes using this altitude oxygen requirement equation, whereby if we know our current inspired oxygen concentration and our current barometric pressure, and we know what altitude we plan to fly at, then we can figure out what inspired oxygen concentration we would need to give at that altitude to provide us with an equivalent oxygenation that we have now. So, for example, if we have a patient who is on an FiO2 of 0.44 at sea level, so at 760 millimeters of mercury barometric pressure, and we know we're going to be flying at 7,000 feet, so you'd have to look it up, but that gives us a barometric pressure of 586 millimeters of mercury, then we can calculate that we would be required to maintain our oxygen levels as they are, an FiO2 of 0.57. Now that's a theoretical concept that's again mentioned in the textbooks. I think in practice we're rarely if ever going to do that, and this is why probably in reality it's a bit more of an art than a science as to how we're going to manage these patients, and based on our experience and lots of other things, because our patients don't have normal physiology necessarily, so they might have some cardiorespiratory problems, which might mean that they might become more hypoxic than we would see based on those previous numbers in healthy volunteers, or they might tolerate hypoxia more poorly. And so what we need to figure out really is which patients we need to intervene on, either by giving them more oxygen or whether or not we're not going to be able to give them enough oxygen in spontaneous breathing patients, whether or not we have to intubate them, and that's very much a judgment call based on that individual patient. But essentially the two things we can do to manage patients who are hypoxic, as we've already described, is we can increase their FiO2, or we can increase this driving pressure of oxygen, and how we can do that is by increasing the pressure in a cabin of a fixed wing, or by positive pressure ventilation. Now, many transport ventilators, including our Hamilton T1 ventilator, have what's called altitude compensation, and our Hamilton ventilator is rated up to an altitude of 25,000 feet. Now, I've tried very hard to look up how this works and what this actually means, and I can't find it anywhere, any explanation of altitude compensation. But in studies, the Hamilton T1 and lots of other transport ventilators perform quite well at different altitudes, and essentially they appear to give pretty much a 10% error rate on their pressure delivered and on their tidal volumes delivered. So if you have someone on a PEEP of 10 it's going to give them somewhere between 9 and 11 of PEEP, for example. And so what my understanding of this is that if we positive pressure ventilate patients, we're essentially taking altitude out of the equation, and so we don't have to worry about that anymore. But if anyone has any more ideas on that or knowledge on that, then please let me know, because it's difficult to find out exactly how that works and what that means for our patients. So moving on to the second change with altitude, which is a reduction in temperature. This happens because as we rise in elevation, the pressure drops, therefore the air expands and it cools. And so we have this ideal gas equation, which is an amalgamation of the gas laws, and you can just see there that pressure is essentially proportional to temperature if all the things are constant. So as pressure drops, which we know it does with increasing altitude, the temperature will drop. And we feel this phenomenon as well when we open gas cylinders, and if you feel the gas escape, it's cold, and that's because that gas is escaping. It's suddenly the pressure's dropped, it's expanding, and it's cooling. And what this means for us is, if as an approximation, the temperature will decrease by 1 degree Celsius for every 300 feet of elevation. And obviously temperatures depend on lots of different things, but this just gives us an idea based on, there's this standard atmosphere idea, which basically allows us to compare the effects of altitude on various characteristics with other things remaining constant. So if the temperature was 15 degrees Celsius at sea level, it's dropped a few degrees Celsius at Katoomba and some more at 10,000 feet, but it's of relatively little clinical significance to us, because all we're going to do is ask the pilot to increase the temperature with the air conditioning, and it's not particularly more fancy than that. Now, the third change with increasing altitude is a reduction in the absolute humidity. And this is because as the air cools, it loses its ability to hold moisture, and therefore that absolute humidity decreases. Now, this is only really going to be of importance to us during fixed wing jobs and long fixed wing jobs. And that's because the cabin is pressurized in the fixed wing by obviously the air from outside the aircraft, and that air has a very low humidity. So what this means is that the humidity in these propeller type aircrafts can drop down to about 10%. And so in patients who are intubated and have an HME filter, it's not likely to be an issue. But if someone is breathing oxygen, which again is drying if it's not humidified, and in a fixed wing, then they could, in theory, become slightly dehydrated, and you might have to manage that with oral or IV fluid intake. Now, the final change to mention with increasing altitude is an increasing gas volume of gas-filled cavities. And this is explained by Boyle's law, which states that pressure is inversely proportional to volume. And so as we increase in altitude and the pressure drops, the volume will increase. So then we have to identify what gas-filled cavities we have, and these can be split up into physiological, pathological, and equipment related. So some physiological gas-filled cavities would be bowel, sinus, middle ear. This X-ray obviously shows someone with bowel obstruction, which is clearly pathological, but in this case you're going to want to make sure the patient has an NG tube before you ascend to altitude, just to equalise that pressure. Some pathological examples of gas-filled cavities are things like a pneumothorax, pneumocephalus, pneumoperitoneum following trauma or surgery, and subcutaneous emphysema. And then equipment examples might be things like your endotracheal cuff and glass vials. So with an endotracheal cuff, particularly in paediatric cases, we're going to be keen to measure the cuff pressure, and just be aware that we might have to take some air out of the cuff as we ascend with altitude. Otherwise the pressure in the cuff might become too high. But if you do that, just be aware that when you descend, you might have to put more air back in the cuff to avoid a cuff leak. And the thing with the glass vials, which things like sodium bicarb and dextrose and albumin sometimes comes in glass vials, if the air above the solution in that glass vial as you increase altitude will expand, and so you just have to be careful with your infusion rates, because that could increase the infusion rate if you're not paying close attention to it. So many of our patients will have some of these pathological gas-filled cavities, and back in the 1980s this paper here states that air transport is absolutely contraindicated for patients with untreated pneumothorax. Now clearly we do transport patients by air with untreated pneumothorax. So that's not the case, even though it's historically thought to be. So what we then need to figure out is which of these patients we need to intervene on prior to a change in altitude. And going back to our altitude chart here, this gives us an idea of how much a gas-filled cavity will expand as we increase to the altitudes we're talking about. So a gas-filled cavity with a volume, for example, of 1 litre, when we go up to Katoomba, that might go up to 1.1 litres, and the maximum height of 10,000 feet would ever be exposed to, it would go up to 1.4 litres. So that just gives an idea about how much a gas-filled cavity might expand. But that doesn't tell us whether or not we need to intervene prior to ascending to those altitudes. Because what we need to figure out is what the clinical significance of this change in the gas volume will mean for our patients. And so someone who has a simple pneumothorax but no other pathology might tolerate an increase in the pneumothorax size, for example, quite well. But in many of our patients with a traumatic pneumothorax who may have a concurrent hemothorax and pulmonary contusions, they may tolerate an increase in size of pneumothorax very poorly, even if it's a small increase. And we also have to bear in mind that if that increase in volume would then start to cause tension physiology, which clearly we would need to address as well. So again, this is where it becomes a bit more of an art than a science, but those numbers give us an idea about how much a gas volume might increase by. But we certainly have a very low threshold for decompressing things like pneumothorax because it's much easier to do on the ground than it is to do mid-air. So ideally, we will decompress a cavity before we ascend to altitude. So for example, with an NG tube, if it's bowel gas, or a thoracostomy or chest drain, if it's a pneumothorax, for example. But if we get into the situation we are at an altitude and a patient deteriorates, then the treatments are to descend in altitude if that's possible, or if we're in a fixed wing, compress the cabin further, or we have to decompress the cavity. So we're either increasing the atmospheric pressure or we're decompressing the cavity. And obviously for something like a pneumothorax in the air, we could put in a pneumofix, or if they're positive pressure ventilated, do a thoracostomy. But there are certain things like, for example, a pneumocephalus, where we don't have the option for decompressing that cavity. And so in those situations, we might ask the pilot to fly at low altitude. So I think pneumocephalus, where we are unable to decompress the cavity, and also where a small increase in volume could have catastrophic consequences, would be an indication for low altitude flying. Another indication classically is decompression sickness, and that occurs when we're exposed to a decrease in pressure, and so the nitrogen gas in our tissues bubbles out of solution, and this is described by Henry's law, which states that the amount of gas in a liquid is proportional to the partial pressure of the gas above that solution. So as the pressure drops, nitrogen bubbles out, and the nitrogen bubbles can lodge in our joints, causing the bends, or they can lodge in our pulmonary vasculature, or in our brain and spinal cord. And again, in decompression sickness, there's no cavity we can decompress, so that would be an indication to fly at low altitude. We would be at risk of getting decompression sickness if we suddenly ascended to 18,000 feet, but it's classically described in scuba divers who are breathing compressed nitrogen gas and then ascend to the surface too quickly. But what we have to bear in mind is that so as I've said, we can ask the fixed wing pilot to pressurize the cabin to sea level, but they have to, because of the pressure differential, they will have to fly lower to be able to achieve that. Or we can ask the helicopter pilot to fly as low as possible. Now, there are considerations for that, and they are that if we're flying lower, the air density is higher, so we're going to be flying slower, and we're going to have increased fuel consumption up to about 30%. So the transfer time will be longer, and we may have to stop to refuel if it's a long trip. We also have to bear in mind that might limit our pilot's ability to get around weather, so we might experience increasing turbulence. So it's not something that is without consequence, but so we have to bear that in mind. But if we have these indications, then it can be justified. The rules in terms of the helicopter in their flight are that the helicopter is not allowed to fly less than 1,000 feet in built-up areas, and it's not allowed to fly lower than 500 feet in rural areas. But because we're a medical emergency service, we are allowed to break those rules, but we just have to be able to justify it clinically. So moving on from the effects of altitude in our physiology, the fifth stressor of transport is the effect of g-force or gravitational force. And Newton's third law of motion states that for every force there is an equal and opposite reaction force. And so when we're accelerated in a force in one direction, we're exposed to a force in the opposite direction, and that opposite direction is measured in as g-force. And it's given a magnitude and a direction, which you can see on the image there, according to different axes through the body. And this force can be applied either in a linear fashion or in a radial fashion as we're going around a corner. Now, the actual g-force that us and our patients are going to be exposed to is relatively small. It's often never really going to be above 2 Gs unless we're in an accident. However, with our patients having some pathological process, again, they might tolerate these g-forces relatively poorly, and so it's something we have to bear in mind. The other thing to think about is the axis by which the g-force is applied, and because we're sat in our chairs, our axis will generally be in the gx direction. Now, we tolerate g-force changes in this axis relatively well. We tolerate forces in the GZ axis relatively poorly, and that's partly because the organs have more room to move, and also the same applies with blood and the hydrostatic pressure. The column of blood has more room to move, and this is the axis that our patients are most going to experience GZ in, because they're going to be supine in the helicopter or fixed wing or in our road ambulance. So they're more prone to the effects of the change in g-force, and they're also in the worst position to tolerate these changes. So you can imagine that a patient who is hypovolemic, for example, because of bleeding from trauma, and you suddenly apply a force in the GZ direction, this could cause the blood to pool in the feet and a reduction in perfusion of the brain and the heart. And the other thing to bear in mind is the position that we have our patients in as we come into land with the helicopter, and because the helicopter nose goes up, we essentially are putting these patients in a reverse Trendelenburg position and their head up, so that again can exacerbate this effect. And this is something that a few paramedics have told me about in terms of patients who are hypovolemic. You can really see a drop in blood pressure as you come into land, and it's described by these effects. So the sixth stressor of transport is vibration, and this is caused by an oscillating force which can either be provided by the vehicle itself or by the environment. And we typically see it in the helicopter as we increase in speed or as we transition to the hover phase is when we get quite significant vibration. And this has multiple effects, which obviously for us as, in theory, well people, it has minimal significance. But again, for our patients who are already physiologically challenged, could have significant consequences. So it increases their metabolic rate, it causes peripheral vasoconstriction, and it interferes with the thermoregulatory mechanisms. It also can cause pain from injuries. If anyone has any fractures or any tissue injuries, it will cause pain, nausea, fatigue, clot disruption, which may be a good thing in something like a pulmonary embolism, but a bad thing in someone who's been bleeding and has managed to form that clot, and disrupting that clot could cause significantly more bleeding. And it can also obviously cause difficulty for us performing procedures, whether or not that's just feeling for a pulse or whether it's certainly using any sharp equipment. Then clearly that's going to be challenging when there's vibration. And the other thing to mention about vibration is that it has been shown it can cause interference with activity sensing pacemakers, so it can affect those as well. Now, how we mitigate the risk of vibration is by driving or flying as carefully and as smooth as possible, and we can certainly, when we do ask our pilots occasionally to do as smooth a flight as possible, which they'll try to do. And the other way we mitigate the risk is by careful padding, so minimising the direct contact between the patient and the airframe, so lots of padding and cushions around the patient. Now, the final two physiological effects we get with transport are related to noise, and obviously the engine noise and the noise in the helicopter and the fixed wing interferes with our communication. And it's also why we have visual as well as auditory alarms on all of our equipment, and why we have to wear ear protection in our helicopter and our fixed wing, because long exposure to these sorts of noise levels can cause short-term and long-term hearing loss. And then the final stress of transport is fatigue, which is clearly an issue for us doing shift work, but it's also exacerbated by many of the other stresses of transport we've already talked about, like noise, vibration and hypoxia. And clearly this is something that might impact on our performance. So the last thing I want to talk about is motion sickness, and this is something that is talked about in the DIPFARM curriculum, but also obviously something that can affect us as well as our patients. And it's thought to happen when there's a conflict between our visual and our vestibular interpretation of our environment, and this causes stimulation of the vomiting centre in the vestibular nuclei. And it's something that everybody would experience if exposed to enough motion, and the amount of motion required to make people feel sick is variable. So some people are just more sensitive to it than others, but we would all experience motion sickness if exposed to enough motion. And also our threshold varies day to day, so depending on how tired we are, whether or not we've had a large meal or we're dehydrated, or our anxiety levels, that can all affect our individual threshold for developing motion sickness. And the way we can manage it can be split into non-pharmacological and pharmacological methods. The non-pharmacological things that have been proven to be effective in treating motion sickness are the things that we can do in the helicopter or fixed wing or ambulance if we're starting to feel sick, is using a stable visual reference point, facing forward, so if you're in the helicopter you can swing your seat around, restricting head movements, avoiding reading if at all possible, and things like distraction techniques, controlled breathing and listening to music can help as well. There's then pharmacological things that we can use. So the only things proven to be effective in treating motion sickness are hyoscine, which has a relative risk reduction of 0.5, and sedating antihistamines like promethazine, cyclozine, that sort of thing. They have a number of needed to treat of 4 to prevent one person developing motion sickness. So these are things that we can give to our patients, but clearly they're both sedating, so they're not things that we can give to ourselves or any of the members of staff. The things that we sometimes use, like ondansetron, have not been shown to be effective in treating motion sickness, no more effective than a placebo. And other things like non-sedating antihistamines, which don't cross the blood-brain barrier and so don't get to that vomiting centre, they're not effective either. So we can't really use any of the pharmacological things, or nothing that's been proven to be effective, but if you find ondansetron helps, then that's absolutely fine. Ginger biscuits, or ginger, is something that has been shown to help, and the number needed to treat for that is 19. So if you're somebody who does feel sick, then you might want to have some ginger biscuits while you're on shift. With these things, the medications and all this kind of thing is better to prevent motion sickness than cure it. So once you start to feel sick, it's quite difficult to break that, and it's better to prevent it in the first place. But these are some things that we can try. And that's comes to the end of it. So in terms of just summarising what we've talked about the 8 stresses of transport and motion sickness at the end there. We've described how this can affect us as staff and healthy people, but also our patients who are able to tolerate these physiological challenges, sometimes far less than we are. We've tried to put it into a bit of clinical relevance and decide when we might think about intervening and what we can do to mitigate the risk and the effects on our patients. And through this we've covered, I think, most of the DIPFARM curriculum, but hopefully there's been some practical use on our day-to-day job and so of interest to all of us who work here at Sydney Hems.